Hello guys, a very good evening. This is Dr. Ranjith here. I hope your day was good and we'll end the weekend on a high note. Let's discuss a few MCQs today and let's see if it's possible for us to learn something new today and let's try to apply that in your real life. Fine. So just give me a second. Okay, let's go on. So a few things to start with as usual. So we have offers going on. So there's an unlock 20 going on for 6 month subscription and anything about that. So if you want to subscribe to any of the Unacademy platform, you can use any of the codes what we have. If you don't have a code, you can use Pathocups. And the targeted batches for you guys as per the goal you are trying to. And hope you will make the best use of it. Right? So by mid of August, we'll be free and we'll continue the special classes, whatever we started. I want to complete the entire pathology in form of special classes. So the link to my profile of the Unacademy will be there below. Click on that and follow so that whenever there's a special class, you'll get a notification. Right? Fine. So without any delay, we'll go on to today's class. So what I'm going to do is I'm going to display you a question. Read through the question and comment whatever comes to your mind. I want you guys to comment for sure. Let's see if we find anything interesting. We'll learn based on that. Let's go. This is the first question today. So I'll mute myself for the next 30 seconds. Please comment on whatever comes to you. It's fine if it's right or wrong, doesn't matter. What do you guys think is the answer? If you want, I'll zoom the image a little bit. That helps you to come to a diagnosis. That will be great. Okay. Anyone wants to start? Okay, Sarath has gone with option A. Anyone wants to add to whatever Sarath said? Or is there any difference of opinion? Let's Satvik has gone with B. Wait. Anyone else wants to add? I want you guys to comment so that it becomes, see, if you make a mistake here, you're not going to remember it forever. That's all. Okay, Tony Foodies has gone with A. Harish has gone with D. Great. Fine. So we have different options here, right? So let's see and we'll understand what will be the right answer and why. First, we'll try to understand if there is any input for me from the question side, right? 30-year-old person came with complaints of weakness and was evaluated. On examination, the patient has tiny purpuric rashes. CBC showed cytopenias. TS was ordered and it's just below, right? So as of now, I don't have any particular clue for me to say, okay, this is probably this tumor. One thing I can say from this history is I'm dealing something which is related to hematological. Could be neoplastic, could be non-neoplastic, something related to hematological I'm having here. And peripheral smear shows few cells, and there are two cells which are highlighted. It is from one of the cases which came to the hospital. Let's see if I can get any information from the image. Before going to the image, we'll look through all the options. First, let's assume what will be the translocations in which diseases I will see. If I can know that, I can easily rule them out and also come to the right answer. You need not pick the blast or whatever cell is there in the image to come to the right answer. Fine. Translocation 922. So which disease do you think you'll have translocation 922? Because Sarat as well as Tony has told that translocation 922 could be the possible answer. So let's try to understand what was there in your mind when you were answering the question. I'm sure you know that translocation 922, the classical finding seen in chronic myeloid leukemia, right? So CML is the disease where I'm going to see translocation 922. Great. Satvik is also right. AML, ALL, CML, CNL. There are multiple of them. But for me, the first possibility which is going to come to my mind is CML. And yeah, to some extent, yes, I'll keep ALL. Fine. AML also will have, CNL also will have. Fine. So if it's a CML, a chronic myeloid leukemia, first, what will be the history? Patients with chronic myeloid leukemia, will they present with purpuric rashes, or is there any classical finding in the history or in the examination which is essential or necessary for me to diagnose CML? I'll have definitely history of a massive spleen, right? The massively enlarged spleen is a very, very classical finding seen in CML. We won't get any CML without a massively enlarged spleen, right? That's first. So on examination, either I should have had a massively enlarged spleen or history-wise, a dragging sensation in the left hypochondrium. That should be there to pinpoint to CML. I don't have that, first of all. Second thing for me, the patient is having cytopenias. Will a patient with CML have cytopenia or leukocytosis? What do you think will be the most common presentation of a patient with CML? CML patients will not have cytopenias, right? They'll have leukocytosis. Leukocytosis with shift to left is a classical finding seen in CML. So it's unlikely to be a 922 translocation if it is CML. Let's consider ALL for an example. What do you think will be the presenting finding for a patient with ALL? So we have ruled out it's not CML. If we rule out ALL, I can rule out option A. Patient with an acute lymphoid leukemias will have generalized lymphadenopathy. Any lymphoid neoplasms for that matter will have generalized lymphadenopathy. And ALL also most likely will have, age is one clue, like Satvik said. ALL is a common disease seen in children, but elderly ALL is not impossible, right? So I would keep age bit down the order. I'm not having lymphadenopathy, which is diagnostic of a lymphoid leukemia or lymphoma. And cytopenias. Again, cytopenias is not the rule, but still I should keep that in mind as well. So because of these two regions, I'm just erasing whatever I wrote here. There's possibility of CML and AL is unlikely, so 922 here is unlikely, right? Let's go to the next option. So Satvik has answered option B, right? Translocation 1517. First tell me in which tumor one can see translocation 1517. Translocation 1517 is a classical finding seen in APML, right? Great. Anita is right. AML M3 or an APML, right? An acute promyelocytic leukemia. Again, let me go back to the history. The patient has tiny purpuric rashes. That could be one of the symptoms in acute promyelocytic leukemia because that can trigger my bleeding and coagulation abnormalities, right? So again, I would have DIC and not a rash, but still some evidence of bleeding manifestation is there. Okay, that's one history for me, which might favor here. Second, if it is an APML, in a microscopy, should the disease have promyelocytes? If they have promyelocytes are actually very, very large cell. They're actually larger than the blast. That's how promyelocyte is being described. Now let's look at the image. So this is my RBC, and if I take the cell, it's okay. It's definitely blastoid because it's at least 1 to 2 times the size of RBC. It's not very huge. If I take a promyelocyte, it will be at least this big. That's one point against to call it a promyelocyte. It's not so big, so I expect to be a promyelocyte. That's first. Second thing for me, if it is a promyelocytic leukemia, APML, you have two named structures or two named findings. What are they? Can anyone tell me what are the named findings seen in an acute promyelocytic leukemia? There are two findings, one based on the nuclear morphology, the other one based on the number of cells in this OR rods in the cytoplasm. I have two findings in APML. OR rod is yes, Satvik and Cosmos is right, but I want a specific finding. APML specifically might not have just OR rods. They have one more important finding, which you call an faggot cell, right? Bundle of OR rod, a very heavily dense granules, and a buttock-shaped nuclei, right? These are classical findings seen in APML. I will have an extremely folded nuclei, which is called as a buttock-shaped nuclei, nice. And I'll have OR rod lot. I'll have lots of OR rods, plenty of OR rods, which is called as a faggot cell. A faggot cell as well as a buttock-shaped nuclei is a very classical finding seen in APML. Now with this information, let me go and look at this cell again. Just zooming it here. Let's have a look at this cell. Do you have granules here? In this cell, whatever you mark, is there any granules or is there any OR rod in any of the cell or any of the blasts which is seen here? I don't see any granules, right? So there's no visible granules, there's no visible OR rods. So for me, it's unlikely to be an APML, right? So it's unlikely to be an APML. So I'm just again erasing whatever I wrote. Since translocation 1517 is a finding seen in APML, I'm not seeing any microscopic findings suggestive of that, so it's not a possibility. Okay, great. Now let's look at the third option, which is inversion 16. Inversion 16 is also a classical finding seen in acute myeloid leukemia. In a patient with inversion 16, I will have one more important finding apart from the acute myeloid leukemia. What is that? Yes, great. That's AML M4. Apart from AML M4, generally inversion 16 has one more important information. Most of the time they will be with eosinophilia, right? It's AML M4 with eosinophilia is a classical finding seen in your inversion 16. Great. It's monocyte and inversion 16. Okay. So one thing for me, great. If I have a patient with AML M4 or anything related to monocytic lineage, I would expect extramedullary blast. When I say extramedullary blast, you must have heard about something called as scleroma. I would expect scleroma in these patients in the form of gun hypertrophy like Satvik said, or I can have a lymph node, or I can have a retroorbital or orbital tissue, or in the skin. I should have something suggestive of that. I don't have any feature in this history that's suggestive of scleroma, so I would keep AML M4 down the order. But still, I'll look at the microscopy. If it is AML M4, like you guys said, it should have monocyte lineage. If a blast is monocytoid, what do you think will be the shape of the nucleus? You can pick them up easily from the normal monocyte. What do you think will be the shape of the nucleus in case of a monocytic blast? It will be the shape will be kidney shape, right? So I don't have a kidney shaped nucleus here. So I'm not going to think of an AML M4 with eosinophilia, right? It's more or less round nucleus here. So it's unlikely to be an AML M4 with eosinophilia. Plus, I don't see eosinophils in this image also. I can kind of rule out three informations. This is a difficult question, right? So when you have a difficult question, do not try to answer it directly. The only option for me is ruling out. By ruling out, I have only one diagnosis here, which is translocation 122. Now let's look at the information given in the history, the microscopy, and confirm what could be my probable diagnosis, right? Just go back to the image again. I'll erase whatever I drew in the image. So I have marked previously itself two important cells here as more characteristic for me here, right? Let's zoom into them. So if you look at this cell, the cell which has been marked, what do you think this is? Can anyone tell me what you're seeing here? The cell has tiny protrusions or blebs. You can see here, this part also I'm having tiny protrusions of bleb. If I go to the other marked cell, again I'm having lots of tiny protrusions and blebs, right? There are lots of tiny protrusions and blebs from the surface of the blast. So whatever I'm seeing is a blast. The only requirement for any blast, be it myeloid or be it lymphoid, is the size. It should be at least 2 to 3 times the size of the RBC. That is suiting here, right? My RBC, easily the cells are 2 to 3 times the size of RBC, and I'm having blebs in the cytoplasm, right? So when I have blebs in the cytoplasm, one of my finding, and mostly my only finding, is AML M7. Megakaryocytes, megakaryoblast will have blebs in the cytoplasm, and translocation 122 is a characteristic finding seen in the AML M7. Fine. So my diagnosis here is preliminary AML M7. Just give me a second, Ram Prakash. So you must have already studied AML M7 in one particular syndrome. Which syndrome will have AML M7? We have Down syndrome. There's a possibility of AML M7 in Down syndrome. In general, the age group given in this question, 30 years, is not the correct age group for AML M7. It will be seen in younger age group only. Fine. Downs can have AML M7. Great. And there is one more finding for AML M7. Okay. So we said that it is a megakaryocytic or megakaryblastic leukemia, right? Let's assume in the bone marrow of this patient, I am going to have lots and lots of megakaryocytes. Tell me what comes to your mind if I tell there's a growth factor secreted by megakaryocytes or a growth factor which is secreted by platelets. What growth factor comes to your mind? What growth factor comes to your mind when I say it's been secreted by platelets or megakaryocytes? I'll come to fibrosis, anicta and osmosis. I'm coming there. It's PDGF, right? Great. I have a growth factor called as platelet-derived growth factor. If you remember the wound healing chapter of Robbins, you must have studied that TGF beta and platelet-derived growth factor are the two factors which is responsible for wound healing and scar formation. That's two important things which is essential for scar formation. Which means the platelet-derived growth factors normal function is to increase fibrosis. First, I have to understand why should a platelet-derived growth factor do this. Then we'll know easily why I am having fibrosis in case of an AML M7. Can I say that megakaryocytes are the largest cell in an bone marrow? Yes, they're the largest cell in the bone marrow, right? When I have a cell which is very, very big, for comparison, my lymphocytes will be this size and my megakaryocytes will be easily this size. So I need some support for it. It cannot just like that float in the bone marrow, because bone marrow is a fluid rich compartment where there's lots of blood in the medulla and cells floating here. So what happens is when a megakaryocyte forms, it automatically creates a platelet derived growth factor and gives it support to itself. That gives my fibrosis. So the normal function of PDGF with respect to a megakaryocyte is to give a support so that it can stay properly in a bone marrow and they are not lost or they don't sink back, right? So if I have a tumor which is coming from PDGF or which is coming from megakaryocyte, what happens is the entire bone marrow is full of things like this. We have entire bone marrow full of things. So each of the megakaryocytes will bring its own fibrous tissue surrounding them, which will automatically cause myelofibrosis fully, right? So myelofibrosis happens, remember this, whenever I am going to have proliferation of the megakaryocytic lineage, it will result in myelofibrosis. We have to verify whatever fact I tell you. If you have seen a bone marrow biopsy of myelofibrosis, they will have dysmorphic megakaryocytes. There'll be increase in number. They look very pleomorphic because myelofibrosis, primary myelofibrosis, is also via megakaryocytes. A great paper. Thank you, and hopefully you do well in your post graduation and then your consultancy for future. All the very best. Okay. So myelofibrosis is primarily thing which is mediated by megakaryocytes. Okay, so that's the reason you guys said that AML M7 will end up in fibrosis, right? And one of the commonest mutations seen in AML M7 is translocation 122. Right? That was about the first question. I'll move on to the second question. Read the question and comment on whatever comes to your mind as an answer. I'll mute myself for maybe 30 seconds. Let's resume soon. Okay, Satvik has gone with option A. Anyone else wants to add to it? I'll ask you guys to comment on the answer. If it's fine, it's completely fine if it's wrong. If it's wrong, you will remember them forever. That's all. Anyone else wants to comment? Only Satvik? Fine. Let's see. Okay. Let's understand what about the image, about the question, and about all the options, right? The question says a polyp is resected from the proximal portion of jejunum. Histologically, the gland contains many absorptive goblet cells supported by a stalk. Images below, which of the following is your diagnosis? Fine. Vishnu has gone with Willis. I have four options: Peutz-Jeghers, Willis, serrated, and my tubular adenoma. Great. So first we look at all the four options. Okay, Dr. Anbu has gone with tubular adenoma and see how they look on a microscopy. Just diagrammatic method. Then we'll come to and compare to this lesion what happened in this lesion, right? I have one more image of the same lesion. We'll look at the image also soon, right? I have four options here. One is Peutz-Jeghers polyp. What type of tumor is Peutz-Jeghers polyp? Can I call a Peutz-Jeghers polyp as an hematomatous polyp? It's definitely hematomatous polyp, right? Satvik has told it's a Peutz-Jeghers polyp. I think the primary reason is there are two things. One, the common location of Peutz-Jeghers polyp is jejunum. Second, most of the time Peutz-Jeghers polyp will have a stalk. Those two are the finding which is classical for a Peutz-Jeghers polyp. But let's see if it's a Peutz-Jeghers polyp or not. Peutz-Jeghers polyp is called as an arborizing polyp. It arborizes like a tree, right? So what happens is, let's assume this is how a Peutz-Jeghers polyp will look. Okay. Let's say that a second. That's how a Peutz-Jeghers polyp will look. When I say it's an arborizing polyp like a tree, The stems and the branches of the tree are made of smooth muscle. These are all made of smooth muscle. The leaves of the tree is nothing but I'm going to have the glands. Hamartama means it's a normal tissue but in a disorganized fashion. That suits to this diagram. In a normal intestine, right? Let's assume it's a completely normal intestine. What will be the layers? The first layer will be epithelium, lamina propria, submucosa, muscle. Can you see or will anyone see muscle between glands in a normal intestine? I won't see them, right? So here I am saying muscle playing the glands. That is, the fashion is not proper or in disorganized fashion. The polarity is not maintained. It's a completely disorganized fashion, right? That's the first thing. I'm having an arborizing pattern. So since it's a muscle-rich tumor here, most of the Peutz-Jeghers tumor will have a stalk. They are pedunculated polyp. They have a stalk. They are not sessile polyp. Right? That's the first finding here for me. So they are pedunculated and they will have a stalk. And it's obviously a hamartomatous polyp. Okay. I just want us to read a little bit more depth about Peutz-Jeghers polyp. Then we look at the image. When I say it's hamartomatous, I also use the term that the polarity will not be maintained. Here also the polarity is not maintained. Normally I should have muscle below and my glands above. But what happens here is the muscle is coming between the glands. So if polarity is not maintained in GIT, that's a problem with Peutz-Jeghers polyp. The STK11 gene or my LKB1 gene is something which is responsible for polarity. It's a tumor suppressor gene, so it'll have a loss of function mutation. So the polarity will be lost. Am I right in saying that GIT is something from oral cavity to anal canal? Yes, it's right from a oral cavity to anal canal. So if I take that, is it right in saying that in a Peutz-Jeghers syndrome, the polarity will be lost right from oral cavity to anal canal, not just in the polyp? In a syndrome, it will be, yes. So let's take that this tumor will have loss of polarity because of mutation in my STK11. That's what happens. Let's take oral cavity for an instance. When I take oral cavity, if it has loss of polarity, what's the lining epithelium of oral cavity? Anyone? What do you think will be the lining epithelium of oral cavity? Is it ciliated columnar, squamous, or columnar, or cuboidal? The lining epithelium of oral cavity is squamous, right? Great, it's squamous. So in a squamous epithelium, what will be there in the lowermost part? Let's stratified squamous. What will be there in the lowermost part? The lowermost part of a squamous epithelium is stratum basale, and am I right in calling that the stratum basale of my squamous epithelium will also have melanocytes? Yes, that's where I have melanocytes, right? So this is stratum basale for me, and I will have melanocytes here. So what makes my stratum basale stay in the lowermost one, and what makes my stratum corneum on the topmost one is polarity. So if in Peutz-Jeghers syndrome, if the polarity is lost, is there a possibility that this melanocytes can come on the top or the melanocytes can go to the bottom? Is there a possibility? That's nothing but loss of polarity, right? Like in the polyp, the muscle came into my epithelium. The lowermost cell of the epithelium, the oral cavity, will come to the top. If it comes to the top, great. You'll have a classical symptom of pigmentation of the oral cutaneous mucosa. It's in and around the face is where the hyperpigmentation happens. The reason for the hyperpigmentation is also the mutation, right? This gives you oral mucocutaneous hyperpigmentation, right? I know the symptoms of the polyp as well as in a syndrome, one associated finding, right? You might not forget this, that's all. So I know the reason for that so that it stays in my mind for a longer time, right? So a Peutz-Jeghers polyp looks like this. Now let's go and look at the polyp in the question and let's see if it's Peutz-Jeghers or not. Okay? I'm just zooming it a little bit in. So if it's Peutz-Jeghers, am I right in saying that muscle should be seen here? There's a polyp, there's a polyp, there's a polyp, there's a polyp, there's a polyp. Are you seeing muscle till this part? Yes or no? Are you seeing muscle here? I'm not seeing muscle there, right? I just have an overhanging mucosa. Yes, the stalk is present. The stalk is present, but I'm not seeing muscle till there, right? So if I'm not seeing muscle till my edge of the epithelium, it cannot be a putrid polyp, fine? Though my history fits in, it's not a putrid polyp, okay? This question is on a difficult side. It's fine to make a mistake. We'll learn more from it, okay? The second thing, when I take villus adenoma and tubular adenoma, we'll compare villus and tubular adenoma together, so it's easy for us to differentiate and come to a diagnosis. Villi versus tubular adenoma. Both villus adenoma as well as tubular adenoma, they are diagnosed based on the percentage of villus architecture. It's not based on the percentage of tubules. If I have greater than 75% villi, I'm going to call it a villus adenoma. Less than 25% villi, I call it tubular adenoma. And in a tubular adenoma, I'm going to have tiny tubules. That's what I'll see in a tubular adenoma, extremely tiny tubules. In a villi, as you know, it will be a finger-like projection like this. That's a villi. Let's go back to the image and see if I'm able to see a villi or a tubular adenoma to come to a diagnosis. Okay. I'll just zoom this again. Are you seeing a villi? Is there any villi seen? I don't see a villi, right? There's no particular villi seen. I don't see a tubule also. There are glands present, but I'm not having tubules. There's no villi present. There's no tubule present. So it's unlikely to be in villus adenoma and unlikely to be in tubular adenoma, right? We'll go back to the question. So this is not a possibility. This is not a possibility. The only thing left for me is serrated adenoma, right? This was also a case which came in a lab. So the first one, AML M7, this was reported as a serrated adenoma, fine? So why it's a serrated adenoma and what do we mean by serrated adenoma and what are the clues for me to come to a diagnosis, okay? So you will start the discussion. I'll ask you a question, try to answer that. We have a colonic polyp syndrome where I have mutation in methyl mismatch repair gene, syndrome called this. It's a problem in congenital colonic tumors and polyps with a mutation in methyl mismatch repair gene. What is the syndrome called this? I'm sure you know that. It is HNPCC, right? Amazing, great. It's hereditary non-polyposis colon cancer. That's where I have all the trouble with the methyl mismatch repair gene, fine? So just have a quick look about HNPCC. One of the findings in serrated adenoma is same methyl mismatch repair defect, right? So what happens in HNPCC? I'm going to have a methyl or a mismatch repair defect, that's all. So now let's understand about HNPCC. Then we'll go into some type of serrated adenoma. Let's divide the colon for a comfort, the right-sided colon and the left-sided colon. What do you think will be the function of a right-sided colon? In general, my right side of the colon, what do you think will be the function? What's the function of the colon in the right side? The primary function is an absorption, right? We'll come to the Amsterdam criteria something. We'll just arrive to the Amsterdam criteria. The primary absorption of the right side of colon is, the primary function is going to be absorption. What do you think is the function of the left-sided colon? The left-sided colon's primary function is to form fecal matter. It's fecal compaction. That's what it does in the left side of the colon, right? The sigmoid colon and the rectum and everything, or the Disney colon does the same thing, right? So if I say the primary function of the right side of the colon is absorption, am I right in saying that there should be more villi? Yes or no? I should have more villi, right? In the right-sided colon, I should have more villi because it helps in absorption. Left-sided colon need not have more villi because there is very less absorption in the left side of the colon. It's the fecal transmit is the function there, right? Okay. If a colon has to have villi, am I right in saying that the stem cells in this particular villi region should be very active? Because villi is one of the most labile cells in my body. It keeps on dying, it keeps on proliferating, keeps on dying, keeps on proliferating, right? So this right-sided colon, the stem cells are extremely active. They're extremely active in the right side of the colon because they have to keep on replacing the shed villi. That's their function. If I have a stem cell which is extremely active, fastly dividing, is there a possibility that they can have mutation? Yes or no? This is a random possibility. I'm not saying it'll have mutation in one particular gene. When cell divides a lot, there's definitely a possibility of a mutation. So can I say in left side colon, where there's not much of a villi, the stem cell is not that active, right? Not that active compared to the right side. Which means now tell me, of these both sides colon, which side colon will require mismatch repair? Which will use the mismatch repair more effectively? Which side colon will use the mismatch repair more effectively? It is undoubtedly the right side of colon, because more active stem cells, there's more chance of a mutation. There's more chance of a mutation. It uses the mismatch repair more commonly, right? Let's assume a HNPCC like disease where my mismatch repair is totally gone. So there is a possibility that this particular right side can have mutations which are going unchecked, and it can give rise to a cancer. If you look at HNPCC, they have more common cancers in the right side of the colon and not in the left side of the colon. That's classical thing. I'm sure you know that, fine. So let's come to whatever Satvik said, the Amsterdam criteria. Amsterdam criteria is one of the criteria for my HNPCC, right? It's a clinical criteria where there are few things called as HNPCC related tumors. It's not just your colon cancer. I have multiple tumors which are HNPCC related. In other words, my only requirement to learn that is, if I can pick up areas in the body which has high proliferation, which is totally dependent on mismatch repair for its prevention of mutation, all of them will have cancers. Is that true? It is true, right? So that's the only thing for me to call it. It's your HNPCC related tumors, right? We'll come to the Amsterdam criteria. The Amsterdam criteria, I should have colonic tumors in one first degree relative in 2 successive generations before the age of 50, and at least 3 cases in the relatives, which should be verified pathologically, fine? Okay. So we'll just have a look at the Amsterdam criteria. In Amsterdam criteria, we have something called as HNPCC related tumors. It's not just colon cancer. If any of the tumors is present in the relatives or in the generation, I consider them as a part of HNPCC, right? So first thing for me is the colon. Colon will definitely be one top of the list. When I say endometrium, can I say endometrium is something which is definitely having lots of emphasis on proliferation on an average every 14 days of the month. Whenever there's a proliferative phase, endometrium keeps on dividing, keeps on proliferating. So during the first 14 days of a menstrual cycle, I do need HNPPC to avoid some errors, right? I'll come to it, Satvik, fine? So endometrium is definitely one of them. That's endometrial tumor is also considered to be one of the HNPC related tumor. Second, it's not just colon. If I take the entire GIT, which part of the GIT do you think will do the maximum absorption? Which part of the GIT do you think will do the maximum absorption? It is small bowel, right? So small bowel is the one which does the maximum absorption. So definitely small bowel requires, small intestine requires my methyl mismatch repair to take care of that. So I'll have small bowel tumors. That's also a classical finding which is related to HNPCC related tumors, right? I can have skin lesions. The skin is also an epithelium. It's a very labile cell, keeps on proliferating. There's a dependency on mismatch repair that also will be there. And there was one more thing, which is ureter. Ureter is the area that keeps on having peristalsis every day whenever the urine is formed. So ureter also will get replaced frequency because of the mechanical damage what it undergoes. So that also requires mismatch repair gene to escape the mutation that accumulates, right? So these are the few important tumors. Sorry. Okay, it's something. So it's colonic tumor, colorectal, small intestine, endometrium, your renal tumors, and your ureteric tumors and skin tumors. These are the HNPCC related tumors which comes to your mind. Fine. Now let's take let's see what do we mean by Amsterdam criteria, right? So Amsterdam had Amsterdam 1 criteria and Amsterdam 2 criteria, and that was the initial discussion. And Amsterdam 2 is where all these HNPC related tumors came, Amsterdam 1 said it's only colorectal cancer, right? So I should have at least 3 tumors of HNPCC related things. It's not just colon, it can be any of them in relatives. When I say relatives, this includes first degree, second degree, everyone. In relatives, it should be biopsy proven. It should be proven on a biopsy. And then of these 3, at least 2 successive generations should be involved. Okay, it should be 2 successive generations should be involved. It cannot be only the cousins, only the brothers. It's not allowed. So at least 2 generations should be involved, and at least 3 tumors should be present, any of the HNPC related tumors in those relatives, and at least one of them should be a first degree relative. They should be at least first degree relative to the other 2 people. Okay, that's 3, 2, 1. Okay, those are the things. And the tumors, at least one case should be diagnosed before 50 years of age. That's also the thing. And like Hatvik said, that FAP should be ruled out. That's first primary thing. Whenever you see a colonic tumor, right? Whenever you see a colonic tumor, the first thing for me which should come to my mind is familial adenomatous polyposis. Familial adenomatous polyposis need not always have 100 or 1000 polyps. I have something called as attenuated FAP, which can have even 30 polyps. That also is accepted. HNPCC also can have 30 polyps, accepted, right? So first I have to rule out FAP, and it should be in less than 50 years, like Y%. At least one colon cancer should be diagnosed before 50 years of age, right? So all these are criteria of Amsterdam, right? So 3 tumors in 2 successive generations, in at least one should be a first degree relative, and if you want, put 0 for FAP, right? See 3, 2, 1, and I have at least one to be diagnosed with less than 50 years, right? This is what Amsterdam criteria means. Fine. We know about HNPCC and we know about Amsterdam criteria. Now let's come to serrated adenomas. We started with serrated adenomas, right? We have to understand what is a serrated adenoma, how it look in the microscopy. Serrated adenoma is a benign counterpart of HNPCC. I might consider them like a precursor, but not exactly a precursor, right? So in serrated adenoma, there are 2 things which is going to happen. To understand the microscopy of serrated adenoma, let's dive into normal histology first. If I am going to draw a normal intestine, what is the thing which protrudes from the surface called as? What do we call this? And what's the thing which deeps dive into the surface called as? We have 2 things here. The top, I call them an villi, and the below, I call them an crypt. Right? As I'm sure you know, every normal intestine has a crypt and has a villi. Perfect. So of these things, the crypt and a villi, tell me, where do I find stem cells? Crypt or a villi? Where do we find stem cells? Crypt or a villi? Stem cells are always found in the crypt, not in the villi, right? So here is where my stem cells are found. What happens is, I'll just zoom this here. The stem cells produce new cells. So when they produce new cells, the new cells slowly move towards the villi and they stay here. Once a cell dies, again a new cell will be produced from the crypt. It slowly moves through the villi and will replace the dead cell. This is what happens in the normal cycle of a crypt and a villi, right? It's in the crypt, okay? So let's assume that this crypt has produced a cell which has a mutation. Let's mark that cell with a blue color. Okay, this crypt produces a cell which has a mutation and which came here. I had one more cell with a mutation. I had 3 cells with a mutation. Am I right in saying that if any cell in my body has a mutation, P53 will identify them and P53 will remove them? Is that statement right? Because P53 is considered the guardian angel of my genome. If you have anything mutated, that will slowly be removed. It will undergo slowly, it will undergo apoptosis, right? Now let's say that the rest of the epithelium here are normal except for the cells which I have highlighted in blue. Okay, rest everything is normal. So over the period of time, the cells will die. It will undergo apoptosis, right? Like you guys said, let's assume we'll erase this, we'll erase this, we'll erase this. Right? So now, if I'm going to draw the crypt, it will look like this. We'll draw the crypt separately. It'll come like this and I have a dip because of a dead cell. Again, it comes like this, I have a dip because of the dead cell. Again, it comes like this, I have a dip because of the dead cell. Does it look like serrations? As my first finding, I'll have serrations. I just gave an example of 3. I might have very high number of serrations, right? That is my serrated adenoma, the first finding. Second finding of serrated adenoma is the crypt. The crypt, normal crypt, will be U-shaped. It should be U-shaped. In case of serrated adenoma, I'm having lots of mutation and lots of proliferation. What happens is the crypt will get distorted. It will become irregular, right? So the first finding in serrated adenoma is serrations. The second finding in serrated adenoma is crypt distortion. This is because I'm having lots of stem cells. All of them are proliferating in a very high pace because there are many mutated cells which undergoes death, and there is a need for more stem cell proliferation to replace the dead cells than usual, right? So these are 2 findings in serrated adenoma, serrations and crypt distortion. Both are due to my mismatch repair defect, which is a component of HNPCC, right? Now let's go to the image. Okay. You look at this image. Can I say that I have a dip here? I have a dip here. I have a dip here. But I have a dip here. I have a dip here. I have a dip here. So I'm zooming it a lot. But if you look at this also, I have a dip here. There's a dip. 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 Right? So these are my serrations. All these are exact serrations seen in case of a serrated adenoma. Right? That's classical serrated adenoma. It'll have crypt distortion and it will have serrations on the surface of the polyp. That's serrated adenoma. Right? As I said, this is a difficult case. Main purpose of this is to understand about HNPCC and also understand how a serrated adenoma looks. When it comes in an exam, at least you should be able to know the theoretical part. It will have serrations on the surface and crypt distortion. Right? Okay. The third question. Viper serrated adenoma, yes, they can progress. They are actually dysplastic tumors. It's not carcinoma institute. They can grow into full-blown adenocarcinoma also. Right? Okay. So comment on the answer. I'll mute myself for 30 seconds. Any options? Anyone? Anyone wants to make an attempt? You have the normal values also given by the side so that it's easy for you to interpret. No one wants to take a call. It's an interesting question. Okay, Viper has gone with IDP. Okay, anyone else? It's fine. Make a guess. If it's wrong, it's completely fine. Okay. Avinash has gone for APML. Ram Prakash has gone for C. Anyone else? Osmos has gone for D as well. Okay, great. Rahul has gone for C and APML. Fine. Let's now understand the question and see how to interpret it and come to a correct diagnosis. Fine. It's a 4-year-old male in the intensive care unit, sedated. You are going for a consult and you see a large ecchymosis, generalized fatigue and everything. Lab findings are shown here. I'm having a platelet count of 45,000. I'll just interpret the given data. The patient is having thrombocytopenia. That's definitely one of the clues present here. Second, the patient's PT is 15.4, but the normal PT is 11.2. The upper limit is 11.2. First, you have to know how to interpret PT. PT is not like any other test. Yes, Satvik, I'll come to that. PT is not like any other test. If I say my WBC count is 11,000, 11,100 or 11,001, I'm going to call it a leukocytosis, right? But with PT, what happens is, if PT is more than 3 seconds of the upper limit, only then I can call it an elevated PT. But here the upper limit is 11.2 and my PT is 15.4. 12, 13, 14.2. It's definitely more than 14.2. So I can call it an elevated or prolonged PT. Please remember this. That's true for PT. And for APDT, again, I should not interpret like any other test. It should be more than 6 seconds from upper limit of normal. Only when it's more than 6 seconds from upper limit of normal, I can call it a prolonged or an elevated APDT. Here my APDT's upper limit is 36. 48 is definitely more than 36, right? So here, second finding for me is prolonged PT, prolonged APDT. I have one more clue here, fibrinogen, reduced fibrinogen, right? So these are the information given in the question, and with the clinical history of bleeding in a 4-year-old kid. ITP is not a possibility, first of all, because ITP will not change PT APDT. ITP is a problem in platelets, so it will affect only the bleeding system. It will not affect my coagulation pathway at all, right? SLE. Lupus will not present like this, right? Lupus can cause hematological problems, but not coagulation abnormalities generally. If at all lupus causes problems in coagulation, what do you think lupus will cause? What all comes to your mind when I say lupus and coagulation profile? Anything which comes to your mind? Any one of you? Okay, can SLE cause antiphospholipid antibody syndrome? Is that possible? APLAS, right? They can cause APLAS. Great. If SLEs cause APLA, it will cause low platelets, it will cause cytopenias, it will cause APLA. If SLE can cause APLA, can APLA change any one of this coagulation profile? Will there be a change in PT or APTD in case of APLA? APTT will be prolonged in case of an APLA, right? That's one of the finding, but PT will be normal, and APLA will not present like a bleeding disorder. It presents like a thrombotic disorder. So I can rule out SLE and I can rule out APLA syndrome, right? It's unlikely to have this finding, right? It will be normal. There are only these two findings here. Okay, so I have only two possibilities here. A congenital hypofibrinogenemia, promyelocytic leukemia. Those are the only two possibilities here, right? When I take a patient with congenital hypofibrinogenemia, which means the last step in the coagulation pathway, which is fibrinogen, is not functioning properly. So this fits into it. Elevated PT fits into it. Elevated APDT fits into it, right? Hypofibrinogenemia will have elevated PT, elevated APDT, and reduced fibrinogen. That's absolutely correct. But will hypofibrinogenemia have thrombocytopenia? They might not have thrombocytopenia, right? So the only thing which I cannot explain with hypofibrinogenemia here is thrombocytopenia, right? Low platelets is not a finding here. That's not a finding in case of an hypofibrinogenemia. So that's ruled out here. That's the only point against hypofibrinogenemia. Otherwise, it's a perfect fit for an hypofibrinogenemia, right? Now let's take acute promyelocytic leukemia. That's the only option left for me. You know, one thing about APML is APML, they're extremely large cells. The WBC count is high. When these large atypical promyelocytes go into a tiny capillary, they kind of squeeze and they kind of rupture. So what happens is APML will release the granules. Releases the granules a lot. Yeah, they do cause DIC. I'm just coming to how they cause DIC. When granules of an APML releases outside, can I say this is like a neutrophil's granule? They are. When APML granules is released in a capillary vessel, can they cause endothelial damage? A widespread endothelial damage, right? They will cause endothelial damage. When anything which causes my endothelial damage, can they trigger DIC? Yes, they will definitely trigger DIC. That's how an APML will cause DIC. It's release of the granule contents which are prothrombotic, which causes DIC. DIC is consumption coagulopathy. So definitely I'll have thrombocytopenia. That's true. PT, APDT will be elevated. That's also true. And fibrinogen level definitely will be reduced. That's also true, right? There's an APML which is causing DIC. That's the right answer. As correctly pointed out by some of you guys, right? Okay. Now let's see. We'll take Satvik's question. Yes, you're right, Satvik. Most of the serrated adenomas will be sessile, right? That's a question created by me just to make sure I want you guys to answer Q-trigger syndrome. But like you guys said, that most of the serrated adenomas will be sessile only. Sessile serrated adenoma is a classical finding, but stalks can be there. It's completely fine. I cannot deny that. If my microscopy suggests of serrated adenoma, I'll definitely ignore the stalk presentation, right? That's not something which will take me away from my microscopic diagnosis, right? Okay. Now let's look at DIC. Just one thing about DIC. Okay. So here, DIC is disseminated intravascular coagulation. I am sure most of you must have worked in the COVID ward. There are two tests for DIC. Okay, Osmus. The reason why it is not SLE is, I said, the only possibility of lupus and coagulation is Apla syndrome. And obviously lupus can cause cytopenias. These are the only two things which happens with lupus and hematological abnormalities. Hemolytic anemia, ITP can be a result of lupus, and WBC counts can reduce it, right? So when it goes to APLA, APLA is a thrombotic disorder. APLA is not a bleeding disorder. I'm sure you know that. It causes abortion and vascular arterial thrombosis. My history here has petechiae and ecchymosis, which is unlikely to be present finding in APLA. That's one point against for me. Then APLA will cause only APTT elevation. APLA will not cause PT elevation. PT will be normal, fibrinogen will be normal, and platelet count can be reduced in APLA. SLE, that's not a problem here, right? So since these two are not a fit, it cannot be an APLA. Fine. If it's not an APLA, it's unlikely to be in lupus or an SLE. And 4-year-old kid is again a very extremes of age group for a lupus erythematosus. Okay. Fine. We'll come back to this. I was talking about DIC, right? So in DIC, there are two tests. One is FDP and the other one is D-dimer. Yeah. Like Viper said that platelet count, fibrinogen low, and D-dimer will be raised. Those are the classical findings seen in DIC, right? So you must have definitely read about these two. Which of these two do you think is specific for DIC? D-dimer or FDP? FDP stands for fibrin degradation products and D-dimer is just a D-dimer. Which of these two things do you think is specific for DIC? You must have done the test during COVID for some of your relatives or yourselves or for patients. D-dimer is undoubtedly specific for DIC, right? Let's understand why D-dimer is specific for DIC and how can I interpret that, right? Let's assume a clot is formed. Let's assume this is my fibrin monomer. This is how a blood clot is formed. Fibrin monomer will not form a clot. It has to, and it will cross-link. Okay? It will cross-link like this. Only when it cross-links like this, it's very, very firm and very stable, right? This is how a clot looks. Both D-dimer and DIC are features of clot lysis. It's not a feature of clot formation, right? So what happens here is, if it undergoes lysis, there are two possible ways this clot can break. The different color. It can break like this. This part alone can come outside, or it can break like this. Just to draw them, I can have fragments which are like this, straight, and I can have fragments which are having the cross links. These are two possibilities of breaking when a clot lyses, right? When a clot lyses, this is what happens. So when I say FDP, it's going to assay all of them. It's fibrin degradation products. It doesn't care what it is. Whatever degrades as result of fibrinogen, I'm going to take that into consideration, right? When I say D-dimer, it will take only the cross links. It's double bonds, right? That's called D-dimer. D-dimer will take only the cross links. So now when I look at this part, the one without a cross link, can I say these single fibers can also break from a fibrinogen, not a fibrin? Can that be a big breakdown product of the precursor molecule fibrinogen? Is that possible? That is possible, right? So this doesn't specify clot formation. It can also be broken fibrinogen, because fibrinogen is a straight molecule, that's all. But I don't want broken fibrinogen. I want broken fibrin, because only fibrin or fibrin, whatever you want to say, means clot has formed. Do you think at any point a fibrinogen will have this crisscross links? It will never have the crisscross links, right? So if they don't have the crisscross links, it's undoubtedly clot has formed. If they have it, undoubtedly clot has formed, which means if I see D-dimer, which means clot was present and the clot has underwent lysis. Clot lysis also is present. That's why D-dimer is very, very specific for DIC. D-dimer is specific for pulmonary thromboembolism, and also D-dimer is specific for your DVT. For any clotting related process, D-dimer is a specific finding. FTP is a very, very sensitive finding for all of them, right? That's the difference between FTP and a D-dimer. Okay. It's just a simple question. I'm sure I want everyone to answer this. Easy one, and we'll complete that and we'll call it off. I'll keep quiet for 30 seconds. Everyone who is here, please do answer. It's a very simple one. Extra has gone with B, Ramkrishna has gone with A. Anyone else? Okay, B again. Fine. Let's see what will be the right answer here. It's a very simple question. It's a 65-year-old person having in a biopsy, it's been proven to have a lung carcinoma. Paraneoplastic syndrome shows elevated calcium levels, right? So when you have elevated calcium as a result of paraneoplastic syndrome, which means it's a tumor producing something which is causing more calcium. A tumor of the lung cannot produce parathormone. It can produce parathormone related peptide. You must have read about this PTHRP. It will produce parathormone related peptides and will not produce parathormone. Parathormone can be produced by only one structure, which is parathyroid, right? So if it's paraneoplastic, they produce some hormone related to the original hormone with the same function. This parathormone related peptide, which is seen as a result of lung cancer. Can anyone answer which lung cancer? Is it adenocarcinoma of lung or squamous cell carcinoma of lung or small cell carcinoma of lung? Hypercalcemia and parathormone related peptide, something which is commonly seen in squamous cell carcinoma of lung, right? Squamous cell carcinoma of lung. It's seen in squamous cell lung carcinoma. Small cell carcinoma of the lung might have your Cushing's syndrome as a classical paraneoplastic syndrome. Lung adenocarcinoma might have your acanthosis nigricans or any skin related disease as a paraneoplastic syndrome. Dr. AJ, I'm really not sure about the NMC bill. What you're talking about? I have not recently gone through any of the articles of NMC. If it's about next exam, as of now, I don't know. If they release something, let's see what happens in future. If you're talking about the 50% government thing in the private, that we'll come to know when the fee structure of the private hospitals are released. So squamous cell carcinoma will have paraneoplastic syndrome of the which produces hypercalcemia. That's always due to my parathormone related peptide and not original parathormone. Which tumor do you think will secrete calcitonin? You're right, Vaibhav. Which tumor do you think will secrete calcitonin? Medullary carcinoma thyroid, right? Correct. So if I'm having a tumor like medullary carcinoma thyroid producing calcitonin, can I call it paraneoplastic or not? Is it paraneoplastic or not? It is not considered to be paraneoplastic, right? So medullary carcinoma thyroid producing calcitonin, which alters the metabolism. It's not paraneoplastic syndrome. I'll come to it, Avinash. Right? It's just a feature of the disease, that's all. It's just a feature of the tumor. It's not considered to be paraneoplastic syndrome. Actually, even medullary carcinoma thyroid doesn't stop with calcitonin. When I take paraganglioma or a pheochromocytoma or a medullary carcinoma thyroid, can I call or group all of them under neuroendocrine tumors? They are all considered to be neuroendocrine tumors, right? When I say a tumor is coming from the neuroendocrine origin, which can function like any neuroendocrine tumor, any neuroendocrine cell based on the degree of differentiation, right? So medullary carcinoma of thyroid can also secrete VIPs. That also is a neuroendocrine secretion. They might also secrete catecholamines. If this is true, the reverse is also true. Paraganglioma, which is also a neuroendocrine tumor, which ideally should secrete catecholamines, which can also secrete calcitonin. So I am not a person to say this should not secrete, this should secrete. The neuroendocrine tumor, based on the degree of differentiation, they might secrete, they might not secrete. But paraganglioma secreting calcitonin is not the common feature. Right? The secreting your catecholamines is a common feature. Okay, K and KN. Calcium levels in case of paraneoplastic syndrome, parathyroid adenoma, milk alkali syndrome, see everything is going to be high. All of them causes increased calcitonin levels, which causes your metastatic calcification, right? That's what happens. The way to differentiate paraneoplastic is I need to identify what's a tumor. That's one. Parathyroid adenoma can be easily, if there's a mass, I can examine, I can use any radionucleated scan to pick up, locate a parathyroid adenoma. Milk alkali syndrome is more of a theoretical question. It's a very, very unlikely possibility to have a milk alkali syndrome in real life. If there's a milk alkali syndrome, it should be ruled out. It's a diagnosis of exclusion because of a rare disorder, right? But all of them will have elevated calcium levels only. The only way is to pick up the primary diagnosis, that's all. Okay. Great. We come to the end of today's session. Thank you for your time. If you have any doubts, do ping me. Next month, there might be a little bit of tight schedule. There are a few projects around Unacademy which are going. We'll have to finish that. Once it's completed, I'll be totally free. I can dedicate more time for you guys. Tell me whatever you wanted to read in pathology. I'll try to create special classes either in YouTube, my channel, or Unacademy channel, or in the Unacademy app. Fine. Thank you for your time. See you soon. Till then, bye bye. Good night. Bye bye.